Hello and welcome to this special edition of Talk to Malik Jones. In this program, we will look at the Gambia's COVID-19 situation as we now enter what is being termed as the second wave of the pandemic. Reports from the ministry reveal that there are about 28 new active cases. The Gambia, you may recall, had its first corona incident in mid-March of this year, prompting the government to start introducing measures that led to a lockdown of non-essential services and implementing guidelines as recommended by the WHO. According to international statistics, the Gambia, with a population of approximately 2.3 million inhabitants, registered corona cases are 3,767, which is 10.16%. Out of all cases, 3,619 cases have been recovered, which is 95% of all registered cases. 123 patients died, which is 3.27% of all registered cases. 34 patients are still ill. But what does this mean? A low rate of cases to the amount of inhabitants can mean that the protection of the people is better. Prophylaxis like wearing mouth-nose masks, social distances, of course, it can also be related to the amount of tests for patients without any symptoms. So, taking countries from the same area, the test should be a little bit similar. Death is a clearer value. It shows the efficiency of the medical service. The higher the death rate, the worse the medical service. In Europe, the death rate is also high, but this depends on the high age of the patients. Let us compare the data from the Gambia with Senegal, which is from all structures the most similar country. Senegal has 16,300,000 inhabitants. There were 16,397 cases, 0.10% cases related to inhabitants recovering rate. Recovered 15,731, which is 95.94% of cases. The death rate is 337, translated to 2.06%, and still ill are 329 people, 2.01% cases. We can see that the cases in Senegal are relatively lower, 0.10% for Senegal to 0.16% in the Gambia, and the death rate too, 2.01% in Senegal to 3.27% in the Gambia. This shows that in Senegal, the people are more sensitized and better protected. Less people out of 10,000 are infected than in the Gambia. The big difference when it comes to the death rate, out of 10,000 patients, 201 dies in Senegal, and out of 10,000 patients, 327 die in the Gambia, can be explained that the medical service in Senegal is much better. About the death rate, the statistics show that Senegal has 64.94% death cases in comparison to the Gambia. Nigeria has 52.43%, and Kenya has 52.84%. African countries present the following statistics to death rates in comparison to the Gambia. To reduce this rate, the medical service in the Gambia must be revamped and equipped to deal with the pandemic. In general, all patients who died in the Gambia are patients who have a very serious progressive form of the illness and need intensive care. Part of intensive care patients in the usage of ventilators. In Europe, around 50% of such patients. What is very strange in all the statistics is the point that in the Gambia, the cases which are still not recovered are extremely low. To talk about this and other issues surrounding the COVID-19 pandemic in the Gambia, I talked to Dr. Abubakar Jain, who is a consultant and a nephrologist at the Edward Francis Small Teaching Hospital. He tells me that the Gambia is entering a second wave.
And when we say there's going to be a second wave, meaning there will be another surge, like the outbreak getting out of out of hand again, basically because diseases, they have a pattern in which we know they go, partly because the disease itself, the things that we are doing to keep it at bay, you lose track of that. Or in fact the disease itself changes, plus the organism that is causing the disease mutate and become more virulent as it was before. As you can observe, if a disease comes, it becomes very, very serious and comes at a height, then start coming down. But apparently with time, the disease itself, environment, even the treatment you give to it, or whatever environmental factors that pertain to it, makes it become mutated. Some strains of it comes that become more virulent than the previous one, and then comes back again, and that could be a surge. And that's what we meant by a second wave. And that could be also because the fact that the precautions you've been doing, you've lost track because it's been on for a long time, then it comes again. And that is another reason why it could be a second wave.
The pandemic began here in the Gambia by mid-March this year. Since then, how many patients have been treated in the ICU?
So it varies. For there is a trend. In March, in April, we never had anybody in ICU. Most of them were mild symptoms, but in June, we had a capacity of almost 8 beds in the ICU, with almost 16 bedded general ward where we see moderately sick patients and moderately sick patients. It was almost full for the whole month. For the whole of June, the whole of June, July, and June and July, yes. For 2 months, we had almost a full bed capacity. And sometimes there's no space for us to bring patients in.
Let's look at how many corona patients died in this hospital in that unit, ICU. Are you okay with that?
Yes. So, strangely enough, not a lot of people died under our care. A lot of people who died, they died before coming to us.
Oh.
So, number of people who died in our care are not up to 10. So all those who came to us never died, less than 10 of them died. But those who died, most of them died before coming to the treatment center. And their diseases were so bad that before they even got to the treatment center, you know how things happen here. You are sick and you have to decide whether to go to the hospital. Even when you decide, then you're waiting for somebody to take you to the hospital, or which hospital are you going to? And at that time it was quite chaotic. People have started running away from hospital. They think that's where they're going to get infection and diseases. So people don't want to come to the hospital. So there was some delay in most of the people coming to the hospital. And some of them just arrived in the hospital. 2 of that cases just arrived at the sanatorium and died right there. In fact, one was brought in an ambulance, the other one was brought by a family. And as soon as they arrived, before we could take them from the ambulance, they died. And those 2 people.
What were you using the sanatorium for?
So sanatorium was for patients who had symptoms.
Okay.
At the beginning we had the time that we had people who were there who were not symptomatic. That's at the beginning of the pandemic. But when that pandemic, when the cases become more severe, many, and we're having more severe cases, then we restricted it to only people who had symptoms. Those were the people we were putting there.
Doctor, I'm still looking at numbers. At the ICU, you may have got a record of people with different symptoms. For example, how many percent of people had fever?
So almost everybody who had a severe form of COVID had fever.
Had fever.
Fever, yes.
And you cannot put a percentage to that?
That is 100%.
Loss of taste? Loss of taste?
Loss of taste, loss of anosmia, that's like loss of smell, is almost everybody who has, even the moderate of symptoms, they will have that.
Headaches?
Headaches, very intense headache. Anybody with a moderate form will have some kind of headache. It's like a flu, so they usually come with very, very bad headaches.
Is it related to the heart problems as well?
Yes. COVID has a I don't want to be very medical in this, but COVID is a disease that can make you have a risk of having clotting, your blood clotting. So anything that makes your blood to clot will have a problem on your heart, on your brain, on your kidney. And so because of that, we have a lot of patients who had strokes and had COVID. They had heart failure, had COVID. They have COVID and have kidney disease. So yes, so all those were part of what we call the comorbidities that were related to COVID. And we had plenty of those things at the time.
Breathing is one of the most acute of the problems, is it?
Yes, it is.
Okay. Now, let me come to how you operate within this pandemic. Do you have enough equipment to protect yourself and nurses?
Okay, Mr. Jones, nobody ever has enough because it's a pandemic. I mean, it depends on the number of cases you have to deal with. For how long are you going to maintain this, and how many staff do you have to be at place to work? But as far as we have had, we had gone to at a peak period. We had a lot of need for PPEs. At some point, we were using almost 150 N95s a day, which you can imagine in a month you're talking about say almost 45,000 N95s. So it's a lot of PPEs that we're using. What saved us was the fact that our surge didn't take that long, and yes, it could have overstretched our system, but because the time we had most severe cases were within 2 months and they start coming down. So our stock levels were coming, while they were coming down, the numbers were coming down. So we didn't face what other people face in Europe where you have to decide whether you or the patient. That never happened. But yes, we had a difficulty maintaining people on oxygen because oxygen need was very high. And at some point, we had to make sure that we ration the oxygen in a way that we show that whoever comes, we know which one to give you at what level you need. And apparently, everybody needs very high level of oxygen. So you find out that then, if you are not at a sanatorium, you are somewhere else. Before you get there, if you are not given the oxygen you need, you may not survive it. So that was a challenge. And you know very well that not all the health facilities in this country has supply of oxygen. So, and you will not know as a patient that you should go to sanatorium first because you have COVID. Even if you want to, you can't come to us first. You probably will go to, say, Bundu Matana Hospital, or you go to Brikama Health Hospital, or you go to, say, Fajikunda Health Center. Then they will be the one to carry you over to us. So if they don't have oxygen right there and your saturation is low, you have a difficulty because you can't stay without oxygen for long.
How big is your ICU and how many beds are there?
The ICU has 8 beds.
8?
8.
And this is the biggest hospital?
Yes.
If there were more cases, how would you cope with that?
That would have been a challenge, a very serious challenge. But thank God, now we have another ICU that is at Deban, which has 10 beds and another 8 beds, which you could even stretch to more than that if need be, because we have another space we've left for, so in case we need to increase the number of beds.
Let's come to one of the biggest problems, or biggest challenges that you may have. In fact, the United States have this problem, this issue of ventilators. Are your ICU units, do they have ventilators?
Okay, so ventilation.
And access to the ventilators?
Okay, so we have ventilators. COVID and ventilation is some kind of a mismatch, and we put a lot of noise in it at the beginning because we didn't know much about the disease. So I will tell you that almost for the cases we've seen here, throughout the time we saw all this number of cases I'm telling you about, we only did an external ventilation for all the patients that were severely ill. We never intubated anybody. And touch wood, thank God there are people who went through that were able to survive. We were able to use the CPAPs. We had ventilators. We have like 4, but we never used it on anybody. Like what you meant by ventilation, that's putting a tube in and connect the person and put the patient to sleep. We never did. But the point is that even those who are able to do that, the outcome is not that good. So at best, if somebody is able to do an external ventilation, they do so much more better, because maybe the severity is not as bad as in those who will need tubing to be ventilated. But yes, we need more of that. We will need more of that. So in case we need to get ready for future crisis like this or whatever looks like this, we need to get ready with more than one ICU. Imagine we're in Banjul, we're in Serakunda, we're in, imagine in Basse, imagine in Bansang, imagine somebody in Yorobao and has COVID. We didn't have a lot of cases in those parts of the country, thank God. But if they are going to be there, how soon will we transport them all the way to this place? So it requires us to expand it. But there's always room for improvement. We're not like any developed country, but that is something we have to work on.
Are people trained in using ventilators?
Yes. So we have, most of the time, most developing world, we always cry about getting machine, getting this. But human resources are the most important thing that you can have to deal with in a health service delivery. You can have all the ventilators here, you can have all the money, but if the people who are going to operate it are not here, it won't make any sense. So we've got a crop of nurses and doctors who have been trained, and even as I'm speaking today, somebody else is training them on how to use those machines. It's been almost all of them, all of it was a class program. They just come in and they've been taught how to use it. And thank God they're young and they're ready to learn and they're able to use it. But I think prospectively we need to get prepared.
Are these machines in place in the hospitals in the event they are needed?
Yes. So we have currently at the sanatorium we have 10 CPAP machines, 2 ventilators. Here we have 4 CPAP machines. If you were here earlier, I'm sure I just had a set that is here. And we have an extra of 19 that have been kept at the stores, so in case we need to redeploy it. So yes, we have. But you can never say it's enough, because I've just mentioned to you that sanatorium, Banjul, but we're not talking about Basse, Farafenye, Basse, so say SL. So in case somebody is there, would they also need it? And if they do need it, will we have enough? That we don't have. But yes, we have machines that we can use. According to what the surge we had, we still had enough machines that we can use for that process.
So there's no need of, there's no problem with ventilators. You have them at the stores, you have them in your ICU centers, and people can work on them.
Yes, so I'm saying that we have a number that at least can be able to suffice EFSTH or Ndemban that we have currently, and sanatorium has already 10 there that are there currently. That is external ventilation, that is the CPAP. And then we have 2 ventilators that are for intubation. They are currently already installed and they're working. But I'm saying that if the numbers increase more than that, you may need more. And we have 19 that I know that are working, that are at the central medical stores. But would it be that if the numbers are more than that, then we'll need more? And if they happen to be that we need to go out of this place to go further or have cases elsewhere, like say, God forbid, in Bansang or in Farafenye or in SL or say in Basse, then this won't be enough. We need more. So as I'm saying, the response is, it has to be an ongoing process, preparing for the worst. And so we need to prepare for that. And I'm sure they already have a center they're fixing at SL, there's a center at Bansang, and there's a center now at Soma. So these are all probably almost at the finishing stage for them to be available for us to use for moderate cases. But you have to prepare, people have to be there so in case they get worse and then they move over, or be there to be giving first aid before they move over to us.
As we speak right now, how many corona patients do we have in the Gambia?
Okay, so currently, as we speak today, we have like 14 patients.
1-4.
1-4. Yes. So 14 patients, they all don't have any severe symptoms. Yes. So only 1 or 2 had symptoms, and those symptoms had resolved, and they were discharged. That's in the last 1 week. But otherwise, we don't have any severely ill patient with COVID. Except for, no, there are 2. One that has just been diagnosed today, that is symptomatic, but that has not been sent to the center yet. I mean, I've just, before you came, that I had a discussion about that case.
Are there differences between the elderly and the young people in terms of getting the virus?
So yes, it's getting the virus. The elderly people have more propensity because their immunity is lower. Secondly, they have more severe forms of the disease, and because of that, they die more. And also because you know that elderly people, that they tend to have more other diseases that will make them more prone to having more severe forms of COVID, as diabetes, the heart disease, kidney disease, and so on, which are all factors that could make you have a severe form of it and probably die from it.
Do you have enough doctors and nurses, drugs in your team dealing with the pandemic?
We had enough for the period that we were here, where we were before. At some point, I'm sure that if we had even stretched it more than that, we're really going to stretch out. I knew that. But as I said, the wave was for 2 months, and for those 2 months, we had enough medications to give. But the problem is that COVID doesn't even have any much specific medication that we give to people. I mean, it's like supportive care. You're trying to give them oxygen. You give them something to avoid their blood from clotting up inappropriately. You give them steroids for those who have difficulty breathing, and then antibiotics, so in case you think there's secondary infection. And then the disease that they come with, if they are hypertensive, you give them blood pressure medication. If they're diabetic, you give them diabetic medication. If they have, they come with pneumonia, other forms of pneumonia, or whatever, they have TB patients, they continue with their medication. But coronavirus itself doesn't have any specific treatment that's been given. So if you say medications, yes, the medications are the regular medicines we give to people. And anybody who come with heart or something, we give you something to stop your blood from clotting. So that is how it has been looked after. We had enough to do that at the time.
Are you expecting more cases in the near future? Give me your honest opinion.
Yes, I am, because I mean we are not different from other countries that are still having more cases. So, of course, now the borders are open, the airport is open, so people will be traveling back and forth. Although with all the restrictions we're doing, you can't stop people from coming. And if you say somebody should go and do a test for 3 days before coming, who says that the incubation period is 14 days? So if the person stays here for more than 14 days and gets COVID, that 3 days of test being negative is not enough. So we should just get ready for the worst anyway. Other countries have it, and we could have it.
Finally, Dr. Chang, what are your major challenges?
So the major challenges are they're divided into different things. Okay, as human beings, you know that compliance with instructions, especially when they are not comfortable, they're difficult to adhere to. Okay, stop shaking hands, put on mask, avoid public gatherings, wash your hands. These are things that are routinely supposed to be methods we use to prevent people from having COVID. But these are things that are quite difficult to maintain, even if it's in your household. I mean, imagine children going to school and you're asking them to put on a mask. Imagine you ask somebody who is going to the market and is a market woman, is selling, you say put on a mask as you're selling at the market. He sees somebody comes, he just takes his mask off and talk to the person. I mean, you go to, say, don't do public, if you go to public gatherings, put on mask. Who are you at your gente and say that whoever is coming to my gente, you have to put on a mask? Or, okay, you have to make sure that every restaurant, every hotel if they're entering there, you have to have a mask. But who are you to make sure that whilst they're even doing the gathering, they have to make sure that the mask is on? These are quite a challenge. It's behavioral problems, it's attitude, and it's quite difficult to impose those on people without having to have the cooperation of individuals. So that's the huge challenge. The other challenge you have is that people don't report illness in this part of the world. People can come, they can seem to hide things amongst themselves. They seem to want to be seen to be well, not to be sick. And because of that, they will not want to go through the rigorous process of having been tested. You hardly see people volunteering to go and get tested, which would have been the best way to do. Even those who come to the hospital, they are unwell, you counsel them that want to do a COVID test on you. No, I don't want to be tested. So you can find out if that's a huge challenge, the cooperation of people being ready to be tested. The willingness of even healthcare personnel to face this. As you can imagine, I mean, if we are all afraid of COVID, I mean, the people who are serving the COVID patients are also afraid of COVID. So to get people to wake up from their houses and say, ask your wife and your children that I'm going to be on the COVID duties, that's a huge challenge. So the challenges are many. But I will tell you, if we're able to go through what we are supposed to go through, we can be able to save ourselves from COVID and save the country from it. But it requires commitment from everybody, including ourselves, health workers, the community, the public, the government. Everybody has to put their hand together and make sure that we are able to protect each other as much as possible. Because we are not endowed with funds like other countries do. And even those who are endowed, they couldn't do so well with COVID. So what we should do, emphasize more, is prevention.
Doctor, thank you very much. It's been a pleasure to have you on this program. Thank you so much.
Thank you. Thank you very much.
Dr. Mustafa Jaite is the resident doctor at the Sanatorium Intensive Care Unit at Mile 2 in Banjul. He gave me an overview of the facility, and as luck will have it, and to our surprise, as we concluded our tour, an ambulance was making its way to the ICU with a patient. Dr. Jaite later on afforded me this interview. This is the sanatorium, the intensive care unit of the Edward Francis Small Teaching Hospital. This is where acute cases of COVID-19 patients are brought in. In here are ventilators, oxygen tanks to help people who have breathing problems. We will take a conducted tour of this facility, and of course later on we will try to talk to Dr. Bitey from the Ministry of Health.
So once we are informed that a patient is about to transfer to this center, sanatorium here, so we have our able nurses who will go with an ambulance to the specific location where this patient has been picked up. So this very van you have just seen is from Edward Francis Small Teaching Hospitals. So the nurse have to prepare it up, put up on the PPE, and they brought in the patient. So already we have 2 nurses on the ground, plus a medical doctor that is involved in all the management and admission of these cases. So basically, it's a center for severely ill patients and symptomatic patients. That means those who need treatment. So we have an ICU here, we have a stable ward, and we have some private rooms that we admit patients. So the protocols are all based on WHO standards, and all the protocols should be observed to make sure that the infection is in control. So as you can just see, an ambulance just arrived, and our able nurses have just gone in, and then they are taking care of the patient.
What do we have inside there?
So here we have an intensive care unit that's called ICU. That place is a place where we admitted severe cases of COVID-19. There we have oxygens that we normally give. We have machines like CPAP, intubation machines, all other gadgets that are used towards treating severe cases. So we also have a side ward, we call it a stable ward. Those patients are the ones who are moderately ill, and they actually not need such intensive monitoring, but although they are symptomatic. So we have to isolate them to make sure that they do not have contact with those who are asymptomatic. So basically we have 2 rooms here that we normally treat, the ICU and the stable ward.
Doctor, can I ask you, do you have ventilators in here?
Very well. We have ventilators. They are brand new ones, and then they are ready to be operated. We have not actually started operating some of them because the need doesn't arise, but we have at least 2 functioning, well-equipped ventilators with automatic flow of oxygen. So this one can cater for at least 2 severely ill patients. But we have other machines that we are dealing with right now, what we call CPAP, and then BiPAP, and also oxygen tanks. So for the meantime, these are the ones we have been using to treat COVID-19 patients. Yes.
Are people trained to use these ventilators?
Yes. Right now, in fact, currently today, as you come here, WHO consultant has been training us, the doctors and the nurses, how to operate these machines. So, alhamdulillah, thank God, most of us are now trained to be able to use these machines. So, hopefully, in the near future, when there is a second surge, may God forbid, we have doctors who are now trained and nurses to take care of these machines. Initially, the training was what was lacking. But this week and throughout last week, a consultant has come from WHO, who came from the United Nations, WHO, and has trained us, and then we are ready to use these machines any moment when there is a surge of COVID-19. So,
Doctor, finally, can you tell me how many patients have died here and how many patients have walked out of this facility cured?
Okay, thank you very much. Okay, the COVID-19, if you look at the statistics, they give you about 120 who died in total, but not all the mortalities occur here. But approximately, we have more than 30 cases of mortality. That's called deaths that occur in this center. We also have more than 300 patients who have marched out of this place that completely recovered and they are back to their normal businesses. Yes, actually we are happy to say that we did one of the best in terms of mortality controls. Although with less equipment and less training, we were able to discharge so many patients who went home, they are fine, they are already in Europe and back to their own businesses. So approximately about 20 died actually in this center. So 20 to 30 patients have already died in this center. Because it is the only center that deals with the critical cases of COVID-19. We have other centers that we operate that are asymptomatic and for isolation basically. But this is a center purely for treatment of severe cases of COVID-19. Yes.
Let me ask you finally, what is your major challenge?
The major challenge is, first I think, is the perception of the people about COVID-19. Because majority of times, people don't actually believe about this COVID-19. So even the patient we brought here, we have to give them a psychosocial support for them to understand this exists and it's reality. So this is one big challenge, even in the communities, when we want people to do the test, and then some of them are reluctant to do it. But also, so far so good, the training was what was lacking. It was a big challenge for most of us to be trained on basic equipment that we have here. But thank God, for the past 1 month, there are a lot of intensive trainings going on. And we hope so we are now fully equipped and to be able to counteract any other surge of COVID-19 that may come in future. But as of now, training is undergoing intensively in all the sectors, and then hopefully by the end of this month, we'll have full-fledged team that will be able to cater all patients and all types of patients that arrive in this center.
Doctor, thank you very much for your time.
Thank you.
It's been a pleasure.
All right, thank you very much. You're welcome.
The Ministry of Health is responsible for all policies affecting health in the Gambia. It is also in the forefront in the fight against COVID-19. Dr. Mustafa Bitey is the Director of Health. He gave me an assessment of the ministry's fight against COVID-19. As we continue our special program looking at COVID-19 in the Gambia, I am delighted to have Dr. Mustafa Bitey, the Director of Health Services at the Ministry of Health. Doctor, welcome to the program.
Thank you. Thank you.
Doctor, first of all, let's look at the test centers in the country. Where do we find test centers in the Gambia? I hope they're not only concentrated in the urban area.
Unfortunately, yes, the test centers, the biggest ones we have, the two are in the region 1. That is, one is in MRC Fajara, and the other one is in Kotu. That is the most active one. That is the national one, national NPHL. That's the National Public Health Laboratory. That's where the bulk of the tests are done. But we also have two others in Keneba, one in Keneba and one in Basse. They are also testing, but not very active because most of the tests are within here. But when they have samples there, they can also do them. We also have 3 in the pipeline. They're already doing them, working on them. One is supposed to be in the teaching hospital. That's EFSTH. And the other one is supposed to be Bansang Hospital. And the third one is Farafenya. So those other 3 are in the equipment are ordered already. They're on their way, but the refurbishment is yet to start. Yeah, we've identified the places. Now they need some work, which we're about to start.
What about the treatment centers where the pandemic is being treated, infected persons?
Yeah, so because it's a process and it's dynamic, initially when we started, there is the isolation rooms which are available in the different facilities, and the COVID, it phases. There is a time when you are preventing anybody entering, and there is a phase when you have few infection and you are trying to contain it, and there is a phase when it has almost like gone everywhere and there's community transmission. Then after that you have vigilance maybe and all. So depending on the stage, and we had some things planned. For example, when we were in the containment stage, then we had a lot of isolation rooms in most of our facilities. On almost all the hospitals, they have rooms identified where if somebody comes who is a suspected case, it's not taken to the rooms with everyone, and until it's confirmed. They are kept somewhere until it's confirmed before they are taken to the treatment room. Those are the isolation rooms. We have them in different facilities. Then we have treatment centers. After they are confirmed, where can we put them? So we have the one in sanatorium. We also have in MRC here, Fajara. There is also in Basse, but we've not used a lot of it. Then we also have Nemban, which is newly furbished. It's been ready, part of it. Phase 1 has been ready since earlier, but we've never had the opportunity to use it because there was no big demand. Phase 2 is also ready now. Now it has up to 92 capacity. So we can also use that. But there's no need yet for us to, except we have probably a surge. So that's it. Apart from that, as a government, we've also planned to develop 8 other facilities, which, the tender evaluation is what they are doing. Initially, we wanted to make it temporary structures. But when the resources required was seen, then the amount was too much. You could, with that amount, also almost make um, permanent structures. And what we learned from Sierra Leone and other countries is when you do temporary structures, when you come 2 years after, 3 years after, it becomes a big liability and all that. So because of that, we said, okay, now let's do permanent structures. But that is for 8 other permanent structures in different areas, each region. Apart from CIR, which has 2, every other health region will get 1.
That is in Upper River, LRR, and the other regions.
Yeah. So no. So like we in the health, we don't have 5 regions. We have 7 regions.
7. Okay.
So we are like here. We have Western 1, which is around Banjul and KM. Then Western 2 is from Birkama to Kalaji. Then we have CRR. Then we have URR. Then we have North Bank is divided into 2. North Bank West and North Bank. Each one of them will have 1. And CRR, because it has the river dividing it, so it will also have 2. But even before those permanent structures are ready, our partners were able to come on board, like the WHO and UNOPS and the UN partners, and they also help us to get 3 temporary structures. I wish you go and see them. They're very nice. So one is in Bansang, one is in Soma, and one is in SL. And each one of those has capacity to take up to 20 people for treatment. So those ones the process should have taken just 6 weeks. But they've promised that by the end of this month, they will be able to finally.
I understand there is a second wave. Do you need more support from national or international bodies?
Yes. So we are preparing for a second wave. Mm-hmm. We are hoping that there won't be any second wave, but we are preparing for one. So yes, so we will need, in the first wave, we got a lot of support from World Bank, the partners, we are in touch with them. What we do is we have regular periodic meetings with all the partners, and we update them as what is going on, and wherever they need to come in, they can quickly support us there. But we'll continue to, sometimes we'll need let's say, to expedite things, to equip those facilities, or like for example now World Bank is building us, with collaboration with them, we are building an emergency center of about 100 beds, and which will have 20 ICUs and all that. So that's going to be very helpful. So we want partners to come in and look at our plan and support any area in that plan.
The treatment centers, how fully are they staffed in terms of doctors, nurses, drugs, let's say ventilators?
Yeah, so good question. So we have a lot of ventilators, but that's not the issue. For example, right now, in our sanatorium, I think the one there, we have minimum of 10 to 15
ventilators.
Yes, some CPAP, some invasive ventilators, some non-invasive. At our store, so that if we have a spike, right now we have maybe more than 10 also there, so which we can bring in quickly in use. And we've given to other treatment centers like MRC, I think, we've given them a few. So, but our people are also trained, and then we can use these things anytime we need them. Like in the peak, you can have a lot of people who will need oxygen, then you quickly bring them on board and use them. But the other thing you mentioned, which is a big problem, is the human resources. So the human resources, is if you look at the ratio of health workers to the population of Gambia is very high. Like the number of doctors needed for the population, we are far from it compared to other countries. Other countries are having like 7 per million. We are like 0 point something per million or something like that. So it's very low. So our human resource capacity is low generally. But there are efforts to increase that. Now there is a medical school, and for the first time in the Gambia, we are training postgraduate doctors here. So before, those type of doctors have to go abroad, be trained, and then come back. Some will not come back. Training them out is very expensive, so you can send a few, and if you send a few, maybe only half comes back or nobody comes back, is a problem. But now you do the training here, but we are only doing the training now in just few sections. The other sections will start coming up. But that's the idea. Sustainability, you can only have it if you start your training in country. And the first step, at least you have a medical school. Second step is to do the postgraduate here.
Doctor, how would you explain the ratio of infection and mortality in the Gambia and Senegal? Gambia seems to be higher than Senegal in terms of the ratio.
Yeah, so infection-wise, I don't think we are higher if you look at the data. But if you look at the mortality, it seems we are higher. So the reason is very easy, and many people have called to like the region, the sub-regional groups are not even happy with what we are doing, our policy, because the policy Gambia and Liberia took was very drastic, and some of our partners are not even happy with it because it brings Africa down and all that. But you see, you look at the general public, you look at the population. Because what we did was, when there was community transmission, in the Gambia and Liberia, we insisted that anybody who dies, no matter wherever, in your house, whether you had symptoms of COVID, you don't have it, whatever reason you die from, you should be tested posthumously for COVID. Because of that, then even patients who normally would not have been tested would be tested, and sometimes incidentally they turn positive. And then even if it is inconclusive, because they are already dead, and you cannot change that, because inconclusive later you have to test again, but because they are dead and it's already inconclusive, you take it to be positive. The reason why we did that was because so that we go and give the family the chance to be contacted and traced and treated as so that they will be protected. Because otherwise, some people will die, and you just say, you leave the family, on the whole it's COVID, and then they will be transmitting it and it will go on. So this was our strategy. But when we look at it, for example, when we had 112 deaths, if we had gone by the normal that other countries were doing, when we had 112, then we would have only reported 70 when we did our own calculation, and that would have been less than 2%, and everybody will be hailing us. But that's not the idea. The idea was to test that. Remember those days. Anyone who dies for any reason in the village or anything, the police will stop you, and then we go and test you, and before you are buried. Nobody could be buried in Gambia unless you are tested for COVID, no matter where you died from. And that helped us to quickly trace people and then get them and know if some of them will not have had COVID, it's okay, but then you will find that somebody who did not have any symptom, nothing, and then we test and maybe it's inconclusive, and we have to treat it as COVID because it's already dead.
Doctor, there is word out there that the vaccine is now out, it's been rolled out. Does the Gambia have any contract or agreement for a possible supply of these vaccines?
These vaccines, they will not be very easy to come by, because, for example, we learned that England, for example, requested for 40 million, and they could only, I think, be assured of 800,000. Ireland, they've already started, Turkey and all that. But for Gambia, what we are doing, what we were sort of informed that what we can apply for, to get for is, which we have started the process, we've already sent our application and all, is we can be only given 20%. And that will not be enough. And so the 20%, what we are planning to do is to give the most vulnerable, and that is only the health workers first. So we are going to first vaccinate probably only the health workers. And if it is enough, if there is, then if the amount we get will also cater for the elderly, those above 65 or above 60, we can also consider them. And maybe after we can also include the security, those in the hospitality area. But I can tell you that the vaccine is not going to be enough. And few countries like Gambia, it's going to take a long time probably before we get it. But we are in the process with COVAX, with Gavi, working with them. And we've already sent in a request. And I'm just from a meeting with Gavi and all the world leaders where they are considering all our requests and all that. And so they are asking for the next step, which is because this vaccine is very new and there should be post-market surveillance. And so, sometimes when you do the research, you don't find certain things, but when you do it to millions of people, you might find that there are some new side effects, and then they can take the company to court. So what we are discussing was about the indemnity. The company doesn't want to take liability for all that if it happens because, they don't know. They just tested it among this group. They've not tested it maybe in Africa and so all that. So maybe they don't want to take, so we are discussing that. And there's another team who wants to take that liability, that okay, if there is that problem, we might take this up and all. But we are in the discussion, and we are hopeful that we will get it. But in reality, sometimes very difficult from what you get from the officials, and when the actual thing comes and big countries bully out some small countries. Some of the big countries, they don't care. They just say, no, we have the money. Even though in paper, all of us need to have some quota according to what we've agreed on. But sometimes they can stop it because it's produced there. They can stop and say, what was supposed to go to Gambia? Let it stay. It cannot leave the country, you know. And then
Finally, Doctor, the German government at one time did help with the supply of ventilators, which I'm made aware at the medical store in Kotu. Have people been trained on how to use those ventilators?
Yes, yes. And even they are currently in a training now.
Oh.
Yeah, by the CDC on how to use the ventilators, and all. That's a 3-day training. Yeah, and it's going on. And those ventilators, the day it came, yeah, it came because I think they gave us like 40. Yeah, and it was very good. But the timing was a little off. It was going to come wonderfully at the peak. And then, but unfortunately it came, but some things were missing and all. Now 19 of them are okay. And so I think we've distributed few to the, because we already had a lot already at the treatment center, and now the cases have gone down, so the ones that need it are not that much. So we've distributed a little, 4 I think, to the treatment center to add there, and they are thinking of taking some to EFSTH and all that, but they will have to keep some in case we have a second surge before they take it to other hospitals. Because otherwise, if you take it to other hospitals now, and the time comes we need it, for the COVID, it may be difficult to retrieve again.
Doctor, it's been a pleasure to have you on the program. I thank you very much for taking your time to be part of this program. Thank you very much.
Thank you very much. Appreciate it.
That was Dr. Mustafa Bitey. He's the Director of Health Services at the Ministry of Health in Banjul. Well, that was Dr. Mustafa Jain. Earlier on, you heard me talk to Dr. Mustafa Jaite, the resident doctor at the sanatorium, and also Dr. Abubakar Jain, a nephrologist and consultant at the Edward Francis Small Teaching Hospital. This has been Talk to Malik Jones, a special edition at the COVID-19 pandemic in the Gambia.